to make sure the recording button was set. So I'm Sarah. I'm a clinical therapist with WVU Medicine. And we're going to talk about trauma and addiction today. I know that this presentation was kind of already talked about a little bit prior to this session here, but it's always nice to have a good refresher for trauma. And you never know, everybody's experiences are different, and you never know when you're going to learn something. You never know when a question's going to pop up. You never know. And so, like, trauma is something, especially with the field of addiction, trauma is something that impacts so many different people in so many different ways. And so it's one of those things that, and again, I might be a little biased, but the more that you kind of hear about it, the more you kind of can understand maybe or catch something differently, or it might change your perspectives with different things. So, um, next slide. So I just came back from Disneyland or Disney World on Thursday. And so because Katie did not share any of her animals last slide, this is a little bit, and she has a pair of little ears on. So this is one of my chickens. Um, and so I took this picture this morning. I didn't realize how difficult it was to take a picture of a chicken wearing Mickey Mouse ears. So you see me in the background there with a little shirt on, but I finally got a picture of Little Bit. So she just started laying eggs, so it's a very exciting time for around our house these days. So just a little disclosure, I might curse a little bit. I try not to curse, but it does kind of pop out, especially doing presentations because I'm very, very passionate. I have no financial gain. There's no conflicts of interest. This presentation, I just want to highlight that it is based on like my own research, experiences, my own opinions. And that's everything. Oh, and I'm also going to include other pictures as kind of my MO. I include other pictures of animals up for adoption through North Central Animal Friends. So and the links will be in the note, like in the picture itself. So next slide. Alrighty, so this is Peppa Pig. She's been in a few of my slides previously. She's still up for adoption, so that's exciting. So she's got the Christmas feel going on. Some of the objections we learn from each other. So if you have a different experience, if you have a question, anything, please speak up or type in the chat or anything, because I don't want people to have a question in their head. If you're anything like me, I have a question in my head, and by the time it gets to the point where we're asking questions, I completely forget about it, or if I don't write it down. So one of the objectives, I want to help everybody learn how trust building and in building trust influences the treatment of trauma and addiction, gaining a deeper understanding, especially of the cultural and social impacts of what treatment and how addiction and trauma kind of can unfortunately sometimes influence each other when it comes to treatment, and understand the benefits of psychoeducation when it comes to treating this stuff. Next slide. So, trauma. So, I'm sure many people have heard the little t and the big T trauma. And normally that's kind of the difference between complex trauma or a big long-term trauma versus a smaller trauma, like a one-time kind of incident, like a car accident. And so like a lot of times we talk about this, and we know that big T trauma and little t trauma impact us all differently. But as time kind of has gone on, we start to realize how important it is not just to talk about the trauma, but actually heal the trauma. And then on top of it, um, how we kind of can incorporate how our somatic issues that might be going on that's connected to that trauma. And so realizing that some people might go through life and not have a single trauma happen at any point in their life, or some people might have, you know, different things happen to them and they might not realize it's a trauma, but they still have these big kind of reactions or somatic responses. And they don't realize what's kind of going on until it's just kind of like they sit down and start to suss it out. Trauma is something that we're still working on recognizing. It is recognized by the World Health Organization, but not yet recognized in the DSM. So we're working on how we kind of define that and how we kind of heal from that too. And we'll talk about treatment options in a slide a little later. So again, we have a growing understanding of how trauma works and how it doesn't what kind of works with trauma and how it doesn't necessarily mean that there's kind of a standard of how trauma manifests, but there is a reason that it is in the DSM, and there's a reason that we have all these symptoms that kind of justify. There's a reason it's in the DSM because there are a lot of similarities, but that doesn't mean that everybody's going to react the exact same way. And some of the things that we kind of talk about and we're really gaining understanding of is interpersonal trauma. And so like we have the direct and indirect trauma where there's the interpersonal, whereas interpersonal is within relationship trauma, and especially when it comes to betrayals, big betrayals. And so a direct trauma is something that happens to you, and indirect trauma can be something that happens to a family member. You can still have a response to that. Just like, when your child is in danger, that doesn't mean that the parent isn't going to have a reaction to a situation where a child is in danger. And so like that is something that I think that we often don't talk about, unfortunately, because when you do have somebody that you love and care about that's been in a very serious incident or trauma or have some sort of impact, it's not just that person experiencing that. It's not just that person struggling with that. It's a kind of community-based issue and a larger thing. And so like I believe that it should be a community-based healing process. And we'll talk a little bit more on that in the future. There's a lot of co-occurring disorders, including, it's not just PTSD. It can be anxiety. It can be a plethora of other things that can kind of go with that. And so just taking your time and sussing out what one thing is and what one thing isn't, and just taking your time with diagnosis. Unfortunately, the way that our world works right now, being diagnosed right off the bat is something that we feel a lot of pressure to kind of do. But making sure you take the time to work with that person and help them help you understand what's really going on. And that just takes time and working and building that trust. Something that often does come with all these traumas is suicidal ideation or homicidal ideation. Not necessarily. Some people, I always like to say that some people like to go inwards with their trauma, but some people go outwards with their trauma. It just kind of depends on the person. And so that suicidal ideation comes when you feel like you have no other way out, versus the homicidal feels like this is the solution to make me feel better. And not to say that they're, obviously they're both not great things, but that doesn't mean that we just kind of ignore them and we don't work with that. And so it's figuring out a way that you can work in a safe environment, in a safe way, to kind of get that person to take the suicidal homicidal ideation off the table, especially while we're in treatment, while we're working on these things. And it's expected, like, as you work on these things will, the suicidal homicidal ideation can fluctuate. And that's just kind of the nature of the beast. Next slide. So we have Corn Muffin here, who is a little puppy that is up for adoption. So if you feel like you want to bring an animal home for the holidays, Corn Muffin is available. So I think when we talk about trauma, one of the things that I often encounter is people not understanding that trauma can happen and they don't have to be in the military. They don't have to be a first responder. They don't have to be a police officer. They don't have to be, kind of on the front lines of something that's traumatic. And so like helping people understand that just because they're not necessarily in these roles doesn't mean that they don't have that mental and somatic kind of issues that go with trauma. And so we see a lot of times, I've seen people just be like, wait, I can't have this. I'm not a soldier. I'm not XYZ, but it's that kind of psychoeducation piece that kind of can come in and help people better understand what's going on, better understand why this is traumatic to them and why they're having these responses, and that these responses have likely saved their life at some point. These responses are there for a reason. And so that doesn't mean that they're there for the reason where they might be reacting in a mall somewhere. That doesn't mean that they're not safe in that moment. It just meant that there's something that's happened back here in their life that has made them feel unsafe, or that they were threatened in some way. There's a lot of people There's a lot of misunderstanding about trauma and how our body responds to some things. And I'm going to talk about that a little bit later to help people kind of come back to themselves and how they can kind of come back and find safety with all that. I see this a lot of times with men, a lot of times trauma manifests as anger. I see this with women as well. It's not exclusively a male thing, but anger is something that is necessarily that is kind of deemed safe, a safe emotion for a lot of men to feel, and so they kind of default to that anger, versus like any other emotion. But anger also helps keep you alive. If you're angry at something, you're moving, you're still alive, you're still kicking. And so like it is kind of it's made its way into almost a coping mechanism sometimes. And especially if you're angry all the time, that means people aren't going to want to get close to you. They're not going to want to kind of be in your bubble or be in your realm because you're angry all the time. And so like it can be definitely a self-preservation technique. Interpersonal betrayal, that's something I kind of touched on a little bit before, but a lot of times we didn't understand, you know, maybe in the past 5 years we're starting to really look on like how interpersonal trauma can really impact people, especially when it comes to relationships. And I think like as we start to learn, like especially as we explore what happens in our amygdala and how our trauma responses kind of interact, we're starting to look at like the benefits of exploring interpersonal betrayal and trauma when it comes to helping people heal with that. Um, that shame and guilt that comes with it, especially when addiction's kind of intertwined with trauma. It a lot of times a lot of people still look at addiction as a moral or willpower, a failing of willpower, unfortunately. And that's something that still happens within our medical system today. And so, unfortunately, that stops a lot of people from getting the help that they very desperately need. And so, like, no, helping people understand that, you know, they're having these reactions for a reason and they're not alone. They're not crazy. They're not, you know, abnormal. They're not just this unhinged person. They're having these responses for a reason. And so, like, helping people understand that this is part of a bigger system that's literally helped them live, help them get to this very point and moment in time. And so like it takes a lot of psychoeducation and it takes a lot of education in general just for us to understand, let alone like how to communicate that. Um, and so making sure that we can put it in a way that helps others understand it, especially when it comes to how they relate it to them and how they communicate that with their families or the people that are important to them. Because again, it's not just a singular thing, that it's not just happening to a singular person. This is likely happening to a bunch of other people that are, it's not necessarily just again just that parent experiencing it. It's everybody interacting with that person. And so when they did studies with rats way back in the day where they traumatized the rats, I'm not exactly sure how they traumatized the rats. I'm not sure I want to know how they traumatized the rats. But they traumatized the rats and they noticed that the next generation of rats were genetically different. They did the same kind of study. The same kind of information was also gathered from people who survived the Holocaust. And so we also know how trauma tends to impact people of lower socioeconomic statuses. They're more likely to be traumatized, and they're also less likely to have access to resources, especially, unfortunately, you know, up until thanks COVID, they weren't exactly able to kind of get the help that they could have needed. And so the beauty of having telehealth be an option for so many people, it's allowing people access to the help that they potentially need to have. And so next slide. Any questions, anything so far? Okay. So like I said, the traumas change us. Everybody knows the standard fight, flight, freeze kind of thing and feign. Those systems are in place. It's hard to tell what you're going to kind of do until you're in that moment. Um, who exactly plans to be traumatized? I don't think that that's really a thing that happens. It is just something that happens. And so the one thing I really like about polyvagal theory is that it talks a lot about co-regulation, especially when you're treating somebody who has trauma. And having that kind of co-regulation is a really, really, really important thing because we have these wonderful mirror neurons that help us connect. And there's even study, or there's even a theory out there where the reason that we survived over Neanderthals was because we have eyebrows. Neanderthals have a very pronounced brow ridge, whereas we don't. And so then there's that, I think it's called like the sad puppy theory or something to that effect. And so like the theory is that our eyebrows help us be so expressive that it helps us use those eyebrows and to communicate and connect with one another. And so we have this wonderful ability to co-regulate, and we have these wonderful mirror neurons that can help us connect and also build that wonderful rapport that we can do, and as we all do as providers. And so like that power of co-regulation, which I'm going to continue to talk about, is so, so, so important when it comes to building rapport, not just when we're treating trauma, but also when we're treating addiction, especially when we start to think about how societal impacts and stigmas kind of play into the role of both trauma and addiction. So we know that there is a difference between people who identify as male and people who identify as female. There is a difference in our brains, and especially when it comes to estrogen and testosterone, because when we have more testosterone in our system, we're more primed to recognize threat versus when we have more estrogens in our system, we are more designed to kind of perceive interpersonal threat. And so these things really kind of factor in when it comes to how we process trauma and what actually traumatizes us. And so that also factors into why our memories are often jumbled when we are traumatized. It might not always come into this is the kind of linear chronological order that things have happened. Sometimes it comes back in pieces. A lot of times it comes back for some people, it comes back as emotions. For some people, it comes back in smells or just feelings. And so, like, just kind of working with the people as they kind of process it and as they go through it, and as they, especially once they start into their journey into sobriety, is a really, really, really important time and a very vulnerable time because all these things that we were kind of ignoring are starting to flood back because we're sober for the first time in however long. And now I have all these emotions. I have all these things, especially if they're going to return to a home environment that the trauma may have happened in. And so that's something really to kind of be aware of as they kind of work on their trauma and sobriety. One of the things that I've really, really noticed with people who are working on getting sober is their dreams, and this is just trauma in general, but the using dreams are so significantly strong, and that connection and that desire to be sober. I have people who have been sober for 10 plus years and they still have dreams where they're drinking again or they're using their substance of choice, and they wake up and they're like, oh, holy shit, was I drinking? Like I like that fear of falling back into that relapse and falling back into that cycle of active addiction is genuinely a fear that they have when it comes to wanting this sobriety and thinking about like I built my life back up to this point. What's the worst thing that can happen? I go back into that cycle of addiction and I lose everything again. And so even just like that traumatic feeling of like, oh my God, did I use again? Like, am I back in this cycle? Have I done, like, have I used again? Have I, really messed up my life that I've worked so hard to get back and that I really appreciate? And so, like, I think that that's a genuine fear. So, again, our trauma neural pathways are really, really well worn because, trauma, it's literally kept us alive. So our brain wants to keep that because it wants to keep being alive and being a brain. All right. Next slide. All right, so we have a little bagel here. So when it comes to addiction and trauma, I think it's, while it can be trauma leads to addiction, and it can be addiction leads to trauma. So I think it's kind of a chicken and an egg thing. So these things can kind of manifest both at the same time, and then it can continue that cycle of trauma, of being traumatized, because we're putting ourselves in very precarious situations through the nature of addiction. And so, like, unfortunately, the neural pathways for trauma just keep getting worn and worn and worn and worn and worn. And so it reinforces us when we use or we go into our addictive behavior. It kind of rewards us to disassociate from that. And so it's just this active cycle of, I want to forget. Oh, now I'm sober. I remember. I want to forget. And so it's back and forth, back and forth. And so it is just like a snake chasing its tail, unfortunately. So we know that people who have high ACEs have larger potential for long-term PTSD, but we know that people who were traumatized as a child are more likely to develop PTSD versus somebody who is an adult. And so, in the sense of, especially when it comes to addiction, because a lot of times adults, it's a little bit easier to get adults into an addiction kind of treatment pattern versus having a child go into a treatment for addiction. And so, like, it's very, very, there's not as much resources for children struggling with addiction versus adults struggling with addiction. And so that the nature of that can become a very complicated thing. And of course, we all know that if you use before the age of 18, you're more likely to develop addiction later on. And so that again is the chicken and the egg. And so it is kind of this thing where you can't always tease it out. You can't always say what came first. And so I also want to talk about, like, behavioral addictions. Behavioral addictions, I know Katie did a presentation earlier this year on gambling, and that kind of gambling awareness has become more and more and more prevalent, especially as she's talked about with our cell phones and the apps that we have on them, and how the ease in which gambling is available to us. And so we have those behavioral addictions, not just with gambling, but with shopping, with so many different things. Social media's now becoming more and more prevalent. The addiction with the internet, the addiction to even the news, and anything that you can't step away from and not have a kind of a discomfort from, or anything you can kind of step away from and not have a discomfort, that is a good thing. But if you step away and you have a large discomfort, like, it's really, really hard to kind of get into that. I see there's a question.
Yes.
Yes, I will get into that.
Okay.
Yep, I can get into that later. And so we know with trauma, I'll touch on it now, actually. We know with trauma, the sooner you can kind of work on it, the better off you are. And so, like, there's so many different practices with children. Like, there's even practices. I know Amanda Newhouse works on, like, children, like newborns, even, because we know that you can be traumatized in the womb. We know that the body does keep that score. We know that there are lots of things that are kind of hit and miss with how we can kind of address this trauma and how we can kind of work on working with children, understand what's going on. And so it's best to kind of look at what, a lot of, obviously, like with children, a lot of times, especially if they're nonverbal, working with that kind of somatic energy and working with making sure that they have the support they need, versus, you can still work on childhood trauma after they're an adult. And so, like, that's one I've had a lot of success with EMDR when it comes to that kind of stuff, where we've established that safety, but we'll go back and work on that childhood trauma. And so, like, that's the beauty of EMDR, because it does kind of follow those neural pathways, and it does kind of bring that stuff back up, but also reprocess it at the same time. And so it allows the brain to show us where to go. And so, as much as I didn't necessarily agree with EMDR in the beginning, once I got the training of it, I really kind of, I don't want to say drank the Kool-Aid, but it did give me the opportunity to see that it works. Not that it works with everyone, just like any treatment, any modality. It doesn't always work with every single person you're going to come across, but it's about figuring out what might work. And then, if you have that training, if you have that experience, if you have the kind of tools in your tool belt to treat that person, great. If you don't, it's okay to refer out. It's okay to ask for a different professional with a different kind of level of expertise, a different kind of wheelhouse. And that's okay, because a lot of times when you first get a client, you're the first person, likely, at least in my experience, you're one of the first people they've ever had the opportunity to trust with the knowledge that they're giving you. And so that is, I think, one of the first and probably one of the more important kind of opportunities to build that rapport. And so taking that time to build that trust, taking that time to really say, like, holy shit, somebody believes me. Because the survivor's guilt thing, like, it's hard enough when you have this trauma, and it's even harder to trust that you can give it to somebody else, like verbally, like tell your story to somebody else, and they still accept you, and they still believe you, and they still see you as a worthy person. Because if this hurt me, how the hell do I expect anybody else to hear this and also not get hurt? But it also shows that, like, this is our job. This is what we do. This is what we're here for. This is why we have the seat for you to sit in. And so it's that rapport. I cannot stress enough how important that rapport is, because it can set the stage for so many people. Because once we get people kind of sitting in the chair and we start to build that rapport, even if you don't click, even if you have to kind of refer out to another professional because it's not in your wheelhouse, it's better to kind of build that rapport and refer out versus not being able to build that rapport and have that person never return. And so that's not to say that every therapist can treat everybody, by all means. Like, I am not the best therapist for little old ladies. I know that. That's who I am. That's not what I'm great for. And that's okay, because I know other people that I can send somebody to. It's making sure that that person that I might be referring out knows that I have the best interest for them in my heart. They know, like, yes, I might not be the best therapist for an 80-year-old woman, but you know what? I trust her for her to get me to the person that I might fit with. And and especially when we're treating trauma and addiction, I think that that's one of the more important things. So even if that person doesn't jive with you, it's getting that person to the person that might be able to help. And so that might be the thing that prevents them from giving up. I don't want to put too much pressure on anybody, because we are humans and we're going to fuck up. We're humans. It's going to happen. And we're likely going to look back and be like, oh, I could have done this, this, and this, and this. But it is a matter of, like, just doing the best we can and being an honest and trying to be constantly doing the next right thing. And so it's just making sure we're putting ourselves out there and making sure we're taking the next right steps. So that was kind of a long-winded, hopefully I answered the question a little bit. Another thing I want to talk about is food addiction. I think that that's something that we overlook a lot, and it's based on some research I've done. It's statistically significant that men tend to have an unhealthy relationship with food versus women, surprisingly. Not necessarily for bulimia or anorexia per se, but just on, like, a really recent preliminary study to kind of start looking into this. And again, there's not a lot of research out there for that. There's not a lot of research, unfortunately, for disordered eating to the point where it's a food addiction. And so, like, as of right now, it does seem like men tend to have a more unhealthy relationship with food versus women. And that could be so many other factors. It could be maybe, it could be tied in with this male loneliness epidemic where food is comfort. And so therefore, like women have more resources to kind of fall on. Women or can build a community easier. It could be several different factors. I'm not exactly sure why, but it's just kind of like a really cool study that it just kind of happened on. And that's at the end of my presentation, the study that I'm talking about. So if you're interested in looking into it. One of the other things I want to talk about, because in the state of West Virginia, PTSD is a diagnosis that is, excuse me, that you can get the medical marijuana card. Again, a lot of studies show that it doesn't necessarily help, at least a study with veterans, it doesn't necessarily help PTSD symptoms. Again, everybody's different. Every strain is different, all these different things, but it's really helping that person reflect, like, is this helping me or hurting me? And so while, marijuana addiction is a real thing, it's looking at, is this really meeting the means to an end? Is this really helping me in the way that I need to be helped in meeting my goals? And so, like, while it does offer short-term solutions, it doesn't necessarily mean it's going to line up with your long-term goals. And so, again, it's a very tricky thing. And Tony and I have really worked hard with some people who have struggled with opiate use disorder and marijuana use disorder, especially people who seem to have some significant trauma. And it is, I think, one of the harder things to get people to see, one of the harder addictions that to get people to see their and reflect on their relationship with marijuana. So it's interesting. Next slide, please. All right, we got Tallulah with two L's. So I want to talk about telehealth. And so, again, there's a lot of great things about telehealth. There's also not a lot of great things about telehealth. One of my favorite things with telehealth is I don't have to go to a waiting room to be seen. And because I hate waiting rooms with this freaking passion. And I use the VA for my mental health services, and I hate the VA waiting rooms. I can't, I'm not a big fan because there's always somebody there doing something. And so I'm a big fan of not having to go to a waiting room. And so some of the pros are flexible location. It allows comfort for treating addiction and trauma. It helps, I think it helps establishing rapport because somebody can be in their home chair with their animals and be safe. But it also is hard to establish rapport because, again, you're seeing each other in person, and so those mirror neurons don't get an opportunity to do what those mirror neurons do. On the other hand, we had, this is what, year 5 of using telehealth, so most people pretty much know their way around it these days. Another pro is that that person can pace or move about, like especially when they're talking about their trauma, depending on the modality you're using. That person can move about, like that person can be doing the things that they need to do, or even just talking while they're kind of doing things that help them somatically, or even stretching or anything. So it allows that opportunity to have that physical kind of release. And again, it increases access and it can help us with safety a little bit in the sense of like, I'm in my house. I know I'm safe in my house. I can kind of work on this extra stuff. I know the trauma stuff. I know I know where this is. I know where my bathroom is. I know where, my windows are. I know nobody's coming into the room because I have the doors locked. I know, I can have a little more control over my own place versus going into somebody else's office because you're not always as comfortable. You're not aware of the smells. You're not always aware of, if somebody's yelling or if you hear somebody crying in the waiting room or, there's so many different things. Again, some of the cons, privacy, making sure that person can establish privacy and there's not somebody who might even be an abuser listening to their conversation. They might not always feel open to talking, especially if they know that their child's in the room or, you know, anything. It's hard to establish privacy. Distractions. You saw my dog come up at the beginning of it. Sometimes they are a great distraction. And so, like, you might be talking about some really, really hard stuff, and then the dog enters the room. While the dog is, it can be a very, very useful tool. I believe animals really, really help us in so many different ways. It can also kind of interrupt us from feeling our feelings, which, again, therapists, of course, we want you to feel our feelings. And so it can kind of put a stop to that, and it kind of can interrupt that whole process of making sure that we are feeling what we're going through. Again, it limits our opportunities to observe what that person's doing versus like making sure that they're, I don't know, not leaning off the camera. As I think Katie was talking about this the other week, leaning off the camera to smoke a cigarette, or they're not doing something. It's hard to limit because there is just like this little square. We don't know. Hopefully they're wearing pants, but you never know. Maybe they're not wearing pants. And so like it's harder to make these observations if they're not fully present in front of us. Um, all right, treatment. Oh, no, you're good. Treatment. So we have Sunny here. So there's so many different treatment opportunities. And so there are several different screening tools which I linked that I found really, really interesting. Um, so one of them is the LEC, that I can't remember the exact name for it because I'm awful at initialisms. But I know the LEC is the life experiences checklist where you can actually give this to your client and they can kind of go through everything that's happened in their life and kind of say this happened and this happened. And sometimes that's a very, very useful tool to help that person, reflect on their life and like say, holy crap, I guess my parents never really were there. Like, where was my mom when I was 12 years old and smoking crack? Like, that is a valid question. And so, like, helping them reflect on, even especially I've had a lot of success in helping people reflect on, like, no, your parents should have been there. No, you shouldn't have been left alone at 6 years old while you know your parent was off doing something else. Like, you should have been safe there. You should have had that opportunity. And so even helping people reflect like this, even having somebody say like this isn't kind of normal per se. And so a lot of times it is an opportunity to help that person reflect and think about like, well, I am having all these issues and having all these feelings and feeling like I'm never safe. Well, if you've never felt safe in childhood, like how do you expect to feel safe as an adult? And so like it helps them explore like why they might be feeling these feelings, or think about opportunities where somebody should have been there or not been there, or somebody should have done XYZ for them. And so that's a helpful tool. The other one is, I think it's disassociating. Um, it's basically how often do you use the internet to disassociate, the DES one here in the middle for the screening tools. It's basically how often do you use the internet or social media to disassociate, which is a really, really fascinating one. And I think that that's something personally I'm going to incorporate more, especially as social media or even the news. I know a lot of people who disassociate while watching the news because it is a lot. It's hard to hear some things, and so like taking a step away from those things, or it is a beneficial thing to do. And so helping people understand like maybe aren't really connected to the moment. And while it is good to not be connected to every single moment in our lives because we would be so insanely overwhelmed, it's making sure that we're staying connected with most of the moments in our life. And so having that opportunity and having that kind of scale to kind of reflect on those kinds of things is really, really important. Psychoeducation is a huge piece when it comes to treatment, not just for trauma, but also for addiction. I'm a big fan of incorporating the family into sessions, especially as like we start to work together, myself and my clients start to work together to help them understand like they're doing this because of this, or, there might be a reason that this behavior is going on, and it's because it's connected to X, Y, and Z. And so, like, having that family member kind of come in and helping that client explain to their family member, like, what is kind of going on and how that family member can help them stay connected to the moment, help them feel safe, what they can do to kind of help them if they're in the middle of a flashback. And so, like, using the family to kind of plan that and what's really feasible for the person's life, because you only get an hour with those people, and some providers get even less. And so that kind of family involvement's really helpful to have the healing continue on into their everyday life. One of the things we do have to be aware of is vicarious trauma. So we treat these things, and while we work with people, we want them, obviously, we want them to get better, we want them to start to heal, we want them to feel better. Like, if we're in this field and we don't want people to feel better, that might be a problem. And so, like, we have to watch out for how these things might impact us. And that's where self-care really kind of comes in. And some people, whatever you do for self-care is what you do for self-care. But I really want to highlight the importance of taking rest and being kind to yourself and sleeping when you need to sleep. And because there's, especially around the holidays, there is a lot of pressure to do, 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 do. We have to get the tree up. We have to, since we have to, do all the things. And so making sure that you take time, especially as the holidays can be really, really traumatizing, and it can be a reminder of a family member who's not there. It could be a reminder of an incident that happened. Holidays can be a very, very big traumatic marker, and it can be isolating because you feel one way about the holidays while you see everybody else be super happy and posting pictures of their Christmas tree. And it could be a stark reminder that your child died tragically. It could be a really harsh reminder and bringing up complicated feelings because your abusive mother is dead. And so, like, just being aware of the holidays and how we can make sure that we're not reacting to the vicarious trauma that we might have been exposed to.
Sarah,
MBT.
we have about 5 more minutes.
Oh gosh, I'm a talker. I'm sorry.
No, you're okay.
I like to get into everything. So social support is really important. Like, there's all sorts of trauma informed groups. There is so many different modalities. Like, just making sure you have some sort of social support, and it doesn't necessarily have to be about one thing or another. It doesn't have to be like a specific. I'm going to a trauma support group for military sexual trauma. Those things do exist, but just going and finding some sort of social support. It doesn't necessarily have to be a support group per se, but just something. There's all sorts of different evidence-based treatment for therapy for PTSD. There's EMDR, CBT, DBT, exposure therapy, cognitive processing. There's oh my gosh, narrative exposure therapy. There's medications for it. And so, like, figuring out what you're comfortable with. And again, it's okay to refer out if you don't feel comfortable, and that's okay. That's okay, 100%. I said support group. There's a bunch of different apps. I have the apps, like a list on the apps, later, and a slide later, so you can click that link or type in that link or whatever. Accountability. The one thing I really, really want to touch on is crisis. So if our client is in crisis, we want to make sure that they have a safety plan in place. If a client, you know, they need people, if they have people to call, if they have like any sort of plan, whatever they need to do to help them feel grounded and touch grass, as the kids say. And so making sure that we can help them understand, if they're in a safe situation, asking themselves, is there a threat? Am I in immediate danger, or is my body reacting to something that's happened in the past? And just kind of using whatever they kind of need to use to help establish that safety. Grounding is a great opportunity. One of the breathing techniques I use, I'm sure everybody's heard of box breathing, but one of the breathing techniques that I enjoy using is you take a deep breath in, you take in a little extra breath, and then you breathe out really hard. So it's And so it's a little bit different than box breathing. And so like it really helps me because box breathing is so slow for me and it's boring. And the double breaths blow out is a more kind of hands-on and interactive. Um, I talked about the body remembering the tip skill, the DBT tip skill, which is temperature, intense exercise, progressive muscle relaxation, and pace breathing. So if you look at tip skill for DBT, it's going to come up everywhere. But one of my favorite things to do is stick my head in the freezer. If I feel overwhelmed, I stick my head in the freezer. It cools me down. It activates that vagus nerve, which helps calm us down. And so like it kind of works together. It's a little body hack. Next, please. Oh, here's our helpful links. So we have the life events checklist, the disassociation experiences skill. We have PTSD apps and a nice little app or a nice little link for just information and education. And we have Uno here who is available for adoption. And I
I
think that's
can
it.
put I can put these helpful links in the recap for everyone.
That'd be awesome.
If my mouse.
And there's some resources. And Picasso, who Picasso has really pretty eyes. I got really excited about that. That's everything. Any questions? I know I'm a talker and I talk really fast.